Today, we're going to talk about simplifying immediate dentures because I know this is something that can sometimes stress people out in the practice. It's the thing that you might get nervous about when you see it on your schedule the next day, and that's something that I want to alleviate for all of you. So, the goal today is we want to think about it from the beginning to end, from impression techniques, step by step, and how to not only make them go smoothly, but also to look really nice for our patients, as well as relining and rebasing, because we would like to do that on a lot of our immediates, and how to go over the common issues and troubleshooting that comes up as we're doing these prostheses. So dentures, a lot of times people think, oh, I'm not going to need to do dentures in practice because a lot of people are getting implants and keeping their teeth as they get older. But we do have a lot of young people that go through drug abuse and drug use, and there's like a drug crisis in America. So even our younger patients are needing dentures, and sometimes it's not a forever solution for them. Sometimes they are planning on getting a full arch fixed prosthesis, but the denture might be the best way for them to transition through the amount of time they have, and also to make it a little bit more affordable for them as they're saving up money for their implants. So there's a lot of different ways that our denture patients may present, and a lot of different reasons why the patients need immediates. They could be any age, and it could be from caries, periodontal disease, or even different medical conditions. So today we're going to go over how to get from beginning to end so we can have our patients leaving in a comfortable aesthetic smile, so that they feel confident, and that you also will feel confident going through each step of the procedure. So step by step, what do you want to do when these patients are coming into your practice? It's really just looking at it from a most basic point of view. And the first step is no different than any of your other practice patients. And sometimes it can be easy to almost jump ahead because inevitably these patients might come in and say, I need to get my entire smile fixed and my daughter's getting married in 2 weeks, and so it always feels so urgent with these patients because a lot of times they may have some degree of dental phobia and they've been avoiding the dentist for a long time is often why they've gotten to the point of needing these immediate dentures. And there's something that is finally spurring them on to take care of their teeth. So a lot of times the patient might want you to move very, very quickly, but you don't want to skip the most important beginning steps. And we'll go through each of these steps together. So the first thing is you need to remember that any immediate patient is going to have to undergo surgery, and you want to make sure that they're healthy enough to do so. So how many teeth are you planning on taking out at once? Can they go through that many teeth at once, or do you need to decrease how many teeth you're going to take out and see how they fare? Do they need to have an INR done? Do they need to have a medical clearance? Are you unsure? Are they a really poor historian? Do they say that, I had a patient one time that said, "Oh, my heart blew up a few years ago." And I said, "Oh, well, do you have any more information than that?" And they said, "No." So in that case, I need a med clearance. I don't know what it means when your heart blows up. Do they need to have sedation? Are they so phobic that they're never going to be able to sit through that number of procedures? Sometimes if they're on some blood thinners, you might want to take out less teeth at first and see how they do, and just make sure that they're able to be stable enough to go through what you want to do. Because the last thing you want to do is plan on taking out most of the teeth and halfway through realizing that you have to stop and now the patient is not happy with how they look and you have to schedule them for another whole day. So next, then you're going to look at their remaining teeth. How many are there? What kind of condition are they in? And where are they? Because the way that I'm going to look at a patient that walks in with every single tooth in their mouth versus a patient that walks in with some of the teeth in their mouth is going to be different. Because I try and avoid, whenever possible, taking everything out and putting a denture in one step. Why? Because then almost the entire denture becomes a guesstimate. If I can take out teeth in phases and take out some back teeth, let it heal a little bit, take a really nice impression, and then my denture is only a guesstimate in the front half. So I know the back half of my denture is going to fit really well. So those are the things that you want to consider. Another thing is, how long is the procedure going to be to take out all of their maxillary teeth in one sitting? What's the condition of the teeth? Are they going to break? Is it going to go surgical? And how tired are they going to be at the end of that session? Are they going to be able to withstand staying longer for inserting that immediate denture? And the other thing you want to make sure you think about is the patient's desired aesthetics. So even before I begin, I want to think about Where's their midline going to be? What's their smile going to look like? And what is their vertical dimension going to be? Because sometimes the patient might also need to have some of their bone removed in addition to their teeth being removed. If their teeth have super erupted over time and some of the bone moved with it, the bone is actually going to be in the way for your final denture. And it also is going to be in the way if you ever want to place any implants, because sometimes patients can have too much bone and it's just as much, if not more of a problem than too little bone, depending on what your final prosthetic is going to be. So when a patient comes in, this is one of my patients that came in and I want to look at what teeth are in the right position compared to her smile line. So I'm not just looking about length and midline, but also facially and palatally. You can see that 8 and 9 are in completely different positions. So I need to start to think about which one is in the right place and what teeth am I going to use as my guide as I move forward so that if I just take an impression and send it to my lab and say, make me a denture based on this, the lab's not going to know which tooth is in the right spot. So I have a couple slides on this later on, but I just want you to kind of start to think about this as your patients come in. When you're designing and planning the aesthetics, you want to look at the patient not just face on, but look at their profile and look at how the teeth are supported in their lips. And a lot of times one of the teeth will be in the correct position and one will be like, can be a warning like, oh, that one's totally in the incorrect position. So for this particular patient, number 8 is far too facial for her. So if I just took this impression and didn't talk to my lab technician, and my lab technician decided to set up the whole denture compared to number 8, when that immediate goes in, it's going to look super, super buck-toothed. She's going to have way too much lip support. It's going to be hard for her to close her lips. And she's just not going to be happy with the aesthetics. And it's also going to be hard for her to talk. When she goes to say 55, she's going to be biting down on her lip and it's just really going to be uncomfortable. So aesthetics are something that you want to assess from the moment the patient walks in the door. Another thing you want to look at on your patients is their amount of cheek support. So if patients have lost vertical dimension over time, they're going to have their lips are going to be turned down at the corner and their cheeks will look sunken in and they're going to have a little bit of excessive profile, inside profile. They're going to have a kind of witchy profile. And that's going to be a clue for you. I know I need to increase their vertical dimension. I need to make their teeth a little bit taller in order to give them the proper facial support that they need. So now that you kind of have a game plan of where you think you want to end up, that's when you can go ahead and impress the patient. So you want to make sure that you're picking the right impression material for the case. So this doesn't mean it has to be always the old school traditional compound border molding and then doing like a polyvinyl or a polyether impression. And it doesn't mean that every case necessarily is the perfect case to scan. And also a lot of cases you can do a really, really good impression with alginate and some of these customizable or moldable stock trays. So it depends on the patient that you're looking at. That's how you're going to decide. So in my mind, when I'm thinking about what I'm going to use, I don't like to think about it in terms of all or none. So if someone asks me, is PVS always better? Or is alginate always better? Or is scanning always better? It's sort of that hint that I give to my dental students. If the word always is in the question, the answer is probably no, because nothing is always or never, right? So what method would you choose? It's going to vary depending on the patient and how they present. So does the patient have caries? And so their teeth are not mobile and none of them are likely to fracture. In that patient, I might feel like, hey, I feel confident that I can use a really definitive impression material and if nothing's going to pull out. In the patient in the upper right, this patient presented, and when he would breathe, his maxillary anterior teeth would move in the wind. Okay. So in that patient, I'm not using PVS because my oral surgeon is going to be upset I'm cheating him out of 3 extractions, right? And the patient is really emotionally tied to these 3 teeth. He does not want to extract them. So until the immediate is coming. He didn't even have a partial to wear in the upper, but he really felt that with 3 teeth in, he looked better than with nothing in at all. So in that case, that's going to be a great case to scan. And if you don't have a scanner in your office, a great case to take an alginate on because you're less likely to pull out more teeth. Sometimes people will say, what if I just put wax over the teeth and then I can use PVS because PVS or polyether or is super, super accurate. So that's what they feel comfortable using. The problem is if you put a lot of wax over the teeth in order to avoid accidentally extracting them, then you're losing all of your reference points. So if I have wax over, for example, in this bottom right photo, the diastema of these teeth and over where the teeth come out of the gingiva and over the incisal edge of the teeth, now when I pour that cast and it's mostly just blobs in the front, it's hard for my lab technician to know where to put the teeth and how to mount the case because I've lost the reference points. So what I always recommend to you is to use the material that can give you the most accuracy without causing problems or pain for the patient. So we don't want to pull out teeth before they're planned to come out, and we don't want to lock into anything. So if the patient has a super huge bridge that has massive undercuts, I don't want to use something I'm going to lock into. So that's when I'll go to an alginate or to a PVS. So remember that regardless of how you're doing it, if you're using a material to impress and not scanning, we want to impress our tissues in function, meaning how the patient's going to move their mouth, their lips, their cheeks, their tongue when the denture's in. So you can use periphery wax or just regular old, like I have blue wax that I add to a stock tray, and then I can heat that up and have the patient move, and that I can get some really nice border molding with that. I can use a PVS heavy body material. You can use compound to border molds, and then your final immediate impression can easily be obtained in alginate. So a lot of times, even if I'm going to take an alginate impression for my definitive denture impression, I'll still border mold that denture even before I load my alginate tray, whenever possible, because I just find it makes my insertion procedure that much shorter that it's worth a couple extra minutes to do so. If your tray that you have, because it's a stock tray, is short of the depth of the patient's vestibule and you know you're going to be missing material, that's another reason to border molds. But another way that you can capture that is you can directly inject some alginate into it using a syringe. So you can use a monoject syringe, you can use a wider syringe. Some of the alginate systems out there come with their own syringe systems, but you want to make sure you cut the tip if you're using a monoject because it's too skinny at the tip, so the alginate won't flow out. So I'll mix my alginate, my assistant's loading the tray, I'm loading the syringe, and then I'll squirt the syringe into my whole vestibule, and then I'll seat my tray and it'll all join together. So alginate does best when it's supported though, and that's why it's good to at least have some of the periphery wax on there as well, so that it's not just going to flop in the wind when you go to pour it. So if you're going to scan, you're not going to scan tissues in function because the scanner is so big that when the patient goes to border mold, if they say they go to move their jaw side to side, they never could, right? The scanner would completely be in the way. So instead, we want to take a very retracted impression. We want the patient to be still, we want the tissue to be dry, and then we want to scan it all in one pass because the scanner needs to see repeatable information in order to stitch those pictures together. Okay, so it can't see the cheek up, and then when it goes to scan it later, the cheek is down because the scanner doesn't know the cheek moves. The scanner just knows what image A looks like and wants to put image B on top of it. So when we're looking at our scanner, we want to make sure that we can get it to look exactly like a stone statue patient. So just imagine your patient is a Roman statue. You're just going to retract them and they're not going to move because you want to keep anything that's movable completely out of the way so you can get something that's very, very predictable and reproducible. So what do we need to capture in our immediate denture impressions? It's really not different than what we need in our definitive denture impressions, with the exception of you need to make sure that any remaining dentition, you capture the occlusal surfaces or the incisal surfaces and the contours pretty well because that's going to be your reference point for setting the teeth for the lab technician. So we want to make sure that we're capturing our entire vestibule the whole way around, all the way to the depth of the vestibule. So sometimes, especially in the maxilla, in the upper jaw, it's hard to get the vestibule in the labial area. A lot of patients that need immediates, they might have periodontal disease, and these teeth are flared a lot buccally. So when you're placing the impression, instead of like a traditional impression where you're going to seat it the tray in the back first and then bring it up in the front, it's not going to work. The teeth are in the way, and then there's no material getting up into this vestibule. So on those patients, instead of seating the tray hamular notch forward, I'm going to seat the tray more like a plane taking off from an airport. So I'm going to, sorry, I went back one. I'm going to seat it from the same path of insertion of the teeth. So if the teeth are slanted like this, I need my tray to come up and over the teeth so that I can get into that vestibule at the same exact time. When I do this, I just want to make sure my tray is not overloaded so I don't have excess going into the back. Another area that a lot of people might forget to look for is the hamular notch. And this is such a critical area because it's the posterior extension of your denture. So you want to make sure that you see where your pterygomandibular raphe comes up, and that is going to be the back end of your denture. If you have trouble seeing it in the patient's mouth, not everyone's is as nice and identifiable as this patient, go ahead with your mirror and slide it along the ridge like this until you feel the actual notch, and then think about and visualize how far back that is. So when you take your impression, you make sure that you still see it in your impression. The next area that you want to make sure that you capture is the posterior palatal seal. So you want to make sure that you get as far back as your denture is going to go. So you don't need to capture the patient's uvula. You don't need to have all of their movable tissue. But when I'm figuring out how far back my denture is going to go, I have the patient say multiple short bursts of ah. So I don't have them say like one like long ah. I have them say like ah, 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 like you're doing CPR, singing Staying Alive. Because the multiple short ahs has the soft palate move more rapidly, and you can easily see where that vibrating line is. Instead of just seeing it like vibrating back all at once, you can see where it begins and ends, begins and ends, begins and ends. And you want to make sure that your tray reaches back that far and your material gets to that area. Now, the fovea palatinae are in between there, but it's not necessarily always in the denture. When they do studies, it actually, some will say in front of, some will say behind. So you might have learned it always has to be in there, but it's not actually true when they look at it. But it's a nice reference point for you to use compared to your individual patient and where their vibrating line is. Another thing is if your patient's been wearing something, so if your patient's been wearing a partial and it stays in with adhesive, you want to make sure that you check for residual adhesive, especially around the rugae, because a lot of times that residual adhesive will be so bulky that it affects how the final denture will fit, and we want to remove it. So hot coffee, I find, is what removes any sort of fixidant or polygrip the best, better than just plain warm water, better than gauze. So if you can just brew some hot coffee for your patient, have them drink it, and have them kind of like swish with it and get that off, it'll help you for sure. Now on the lower, we want to make sure that we capture our retromolar pads because these areas are actually where we should get the most support from our denture. And I would say most dentures that I see, this area has been accidentally lost in the impression or accidentally trimmed off. And so that's why lower dentures, another reason why lower dentures tend to move a lot. So lower dentures already have the world stacked against them with how much the tongue moves. So let's try and see what we can do to keep it a little bit better by making sure we capture this retromolar pad. For the distal lingual flange, so the area between the tongue and the ridge, that's where you're going to get the most like grip of your lower denture. So I like to feel how deep this is with my finger first and see how much should I expect to grab. And then I like to, while my finger is in, I have the patient move their tongue to the opposite side and I see if my whole finger gets kicked out or if it's able to stay there. You can also use a mirror, but sometimes it's hard to visualize the mirror. So I just put my finger in there just like I'm doing an oral cancer check, and it helps you to figure out how much space you have. And this is an area that I for sure love to make sure I have some border molding material in there. And if I'm picking an arch that doesn't have a lot of ridge, this is what I want to impress whenever possible. If the patient has a ton of ridge, then it's not a big deal to scan because they have plenty of ridge to grab onto. But if in a patient that has a very deficient ridge, I'd like to at least take a traditional impression, and then I can always scan my impression to go into a digital workflow. The lingual frenum is definitely an area that you want to capture with the patient actually moving their tongue. And another trick that I like to do is not just have the patients moving their tongue like into each cheek and licking their lip, but another trick that I find forms the distal lingual flange as well really nicely is having the patient push their tongue against the roof of their mouth onto their incisive papilla. So behind where their front teeth are, push really hard on that rugae, and that gives a better idea of what that lingual flange looks like in function. Because unless you're hanging out with little kids, you probably don't spend a lot of time with your tongue sticking straight out of your mouth. And a lot of times that's going to over shorten our denture and make the flange very thin. So this gives a better idea of real functional movements of the patient's tongue. And of course, just like on the upper, we want to capture our vestibule. We want to make sure that we have it the whole way around, and especially that we keep the lip out of the way of the impression. So whenever I'm making my impressions on the lower or the upper, I always keep my two fingers in the vestibule on each side so that the lip never gets into the impression and then has to be pulled out. I keep the lip out of the way as I'm seating the tray. As the tray goes in, my fingers pull the lip down and out of the way. So, because once the lip gets into the material, now there's not enough material there to capture your vestibule really nicely. So once I have a beautiful, beautiful impression, I can send it off to my lab. They can pour it up and they can make me some nice wax rims. And now I can obtain my jaw records. I can get my bite. I can ensure that I like my vertical dimension. And now I'm going to give the lab any information I need in order to make my final denture. So I need to make sure that I document for my lab, where do I want my midline to be? Where do I want my smile line to be? And where do I want my centrals to be facial lingually? So in terms of obtaining jaw records, you want to make sure that you're getting the patient's relationship of their upper to their lower jaw to match up together as well. So in terms of the midline smile line, this is going back to that picture I showed before. How does the lab know where to set the teeth compared to your individual patient? So a lot of times it's a matter of just finding what I call the right tooth. So in every mouth, there's usually one tooth that's in the right place in at least one dimension, right? So none of these teeth look beautiful, but number 10 is in the right place, maybe in terms of the patient's smile line. And then I can tell the lab, follow 10 for the position of the teeth. The new 10 should be the same length as this existing 10. But then you can say, but the midline is not accurate. I need the midline to be 1.5 millimeters to the patient's left. So now I need to know with jaw records, am I able to skip that step? Do I take a bite, or am I able to just go directly to a denture? So it depends. I can skip that step if I scanned them for a digital denture and their bite was repeatable. If I'm maintaining their vertical dimension and the cast could be hand articulated. And if the patient has a reliable right tooth and you have some concept of where the teeth are going to go in space and you remember to write it down and record it. Because the thing is, you might look at them and say, yeah, it looks right. And then you don't write it down. You see how many other patients in a day, and 2 weeks later, your lab calls you and you say, oh, whoops, I don't remember. So that's where you want to think about, can I skip a step here? Possibly. So when I look at these patients, I want to think to myself, of these patients, who can skip their try-in appointment? So the patient on the upper left has so much wear. Their teeth are so worn down. I can't skip a try-in appointment for this patient because I need to figure out where I'm going to put their teeth vertically. How tall can their teeth be? How much of the height do I want to come from the upper versus the lower? So on that patient, I definitely want to do a try-in, and I don't really have a lot of teeth to go off of. And I could even in the try-in mark their exact midline on a wax rim. So I wouldn't skip a try-in for that patient. On the upper right, if I took a traditional impression for this patient, there's no way the lab would know how those casts articulate to each other. It would just be impossible. So I'm definitely going to need to make a wax rim and bring the patient back in. On the lower left picture, this patient, if I'm not changing their vertical, I might not need to bring them in. Because if we say extracted the posterior teeth and left first premolar to first premolar, it might be stable enough to articulate with the lower. It might not be, it might be. Or the patient might refuse to take out anything more than the posterior molars and you're doing an extraction of second premolar to second premolar, right? Then that I could hand articulate and I might not need to bring them back in for a jaw record. And then on the lower right, Again, there's not enough areas for the lower jaw doesn't have enough teeth in order to hold those casts together in a repeatable way and know exactly where they're going to be if I took traditional impressions. But in that patient, if I scanned them, then I might be able to skip that try-in. So again, I can skip try-in with this if the patient is scanned for sure, because I'll be able to maintain the vertical dimension and I can tell the lab what tooth looks good, and the lab is going to take a scan of a patient. It's going to look like this. And they can then look at the teeth and they can digitally carve the teeth off and set the teeth for you and actually know in space exactly what the denture is going to look like, which is why it's so much nicer compared to when you do it analog. Of course, when you grind a tooth off and it's just gone, there's no more reference point anymore to go back to. So when you're looking at a 3D printed denture versus a handcrafted dentures, either type of denture can be made from a scan, and either type of denture can be made from a physical impression. So as long as you take a really good bite, the lab can then go to finish from your scan. So if you scan the patient and you have a very, very repeatable bite, they can just go to finish. Sometimes you could scan the patient and you can't go to finish without a try-in because the patient didn't have enough teeth and you didn't know where their jaws actually would be in relation to each other, because I like to put my patients in centric relation for my dentures in order to avoid problems on insertion. So if you can't do that repeatedly, or if you can't do that at your vertical dimension that you want, then it makes sense even in a scan denture to bring them back. So here you can see the reference points. I could tell the lab, I want to follow the midline. I want to follow the incisal length of number 9. So the next step is for our extraction. So you want to make sure you coordinate that schedule. So it might depend office to office, or even if you work in multiple practices, it might depend on which office you're in. Are you doing the extractions? Is a specialist doing the extractions? Is it in the same place? Does the patient have to drive in between? So you want to make sure that you're coordinating with both of those staffs. And I also always like to check in with the staff before. So I don't want the patient to have teeth extracted until I know my lab case is in. Not it's coming in, not it's in the mail. I want to see it before that patient has any teeth taken out. The other thing is I want to make sure that my patient doesn't lose anesthesia before I'm going to see them, because I'm restorative. So I'm putting the denture in, I'm not taking the teeth out myself. But I don't want the patient to have their teeth out at 8 a.m. and then me put them in at 5 p.m. because the patient's going to already be swollen. They're not going to be comfortable, and it's going to be a terrible experience for them and me. So I really want to coordinate, and I work with a lot of great surgeons who are good about this, and their staffs are good about this. If they're taking them out in your practice, you also want to show the patient when you can the dentures before you take the teeth out. I think that in terms of just a practice builder, a rapport builder with your patients, and just like a really nice thing in terms of human nature, to have all of your teeth taken. And I love to be able to show them in that, so worried right before they go into surgery. Hey, here's your smile. You're going to leave today with an awesome, awesome smile, better than you came in with today. And I find that it kind of helps them calm down, take a deep breath right before they go through the surgery, especially if they're a surgery phobic patient, because now they have something to look forward to instead of like wondering how it's going to look. And I always, always, always make sure I can see them the next day. I remind the patient when we're confirming both appointments. So when I go to insert, I want to make sure that I examine the dentures outside of the patient's mouth first, and then check each in the mouth one at a time. So again, it's so exciting. You want to get everything in. And it's so easy to just take it out and put it in the patient's mouth, because again, it's always a rush. Someone's getting married in 24 hours after these are going in a lot of times. So you want to make sure that it all looks good. So when I'm looking at the denture outside of the mouth, I'm going to use my eyes and my fingers. So I want to check for any sort of nodules on the inside that's going to cause my patient a sore spot, any rough patches, any sharp angles, and then I'm going to adjust it. So I always say, if it feels sharp to your finger, it feels like a knife in the mouth. So just run your finger all over everything. And I actually do this like when I'm not looking at the denture, so I don't believe that, it looks shiny, so you believe it's all smooth, but it can feel really sharp. So I glove up and I grab my nice polisher. So I like to use some carbide finishing burrs and then some polishing points so that I can get everything nice and smooth. So I want to make sure all of my edges are round. There really are no right angles in the mouth in terms of where the denture would contact. So if you see a right angled corner anywhere in your denture, you're going to just want to smooth that off. And then I'll use my red striped acrylic burr and I'll polish my polishing points and then pumice it and give it back to the patient so it's nice and smooth. And with the intaglio surface, the inside, you want to make sure that you remember you're just taking off any sharp spots or blebs or nodules, but you're not going to polish that area because then you'll lose your suction and retention. So once I know it looks nice outside the mouth, feels nice outside the mouth, then I'm going to put it into the mouth. And I'm going to check each denture one arch at a time. So again, I'm not putting both in. I know the patient wants that aha moment. How's it look? We're going to try one at a time first. And I'm going to put the denture in and I'm going to gently do my border molding movements for two reasons. One, it helps it actually sit all the way up because patients numb, their lips are maybe in the way. And then I'm going to make sure it's not overextended. So if I have the patient pucker and the denture just drops right down, well, then I know it's overextended in the area that I border mold for puckering, which is in my labial vestibule. If I have the patient move side to side and that makes it drop down, well, then I know it's overextended there. I'm also going to check for pressure spots with my pip paste. And then after I do that with my upper, then I'll do that with my lower. And then I'll check them both in the mouth, and then I'll check my occlusion, and I'll go ahead and check any pressure spots again. If the patient has a lot of bleeding, a lot of times I don't use pip paste. I actually just use the heme makes a really nice pressure indicating paste because where it stays is, especially because they're usually like clotting at this point, so it's moving pretty slow. So where it shows through is where you have a high spot, and where it kind of collects, you don't have a high spot. So it's a nice little trick. And then follow-up is one of the most critical things for immediate dentures. It's really important to see the immediate denture patients 24 hours after surgery and then again at 1 week. And I try and delay relines until primary closure is achieved. It's just messy. I don't like to leave soft reline next to a healing extraction site because I feel like it's kind of hard to clean. It stains with blood, and I feel like it's just going to hold more bioburden right next to my extraction site. So I usually don't reline on insertion day, but you can. And if you need to reline over sutures, a nice little trick is if you get some really wide Teflon tape and you can just lay it over the sutures before you reline, then you won't get a ton of it into the nooks and crannies of the sutures. And especially if you have any still open tissue that needs a little bit of, that's going to heal by secondary intention. So when we want to reline and rebase our immediate, so let's go over how and when we want to do this. So relining is what we're going to do if we have residual ridge resorption. So we're going to see this, of course, we expect to see this within a year of our immediate denture placement. Sometimes you might do this not even on an immediate. If you have a patient that's geriatric or they're chronically ill and they can't tolerate getting a new denture made, or even if people have drastic weight loss, which we're going to keep seeing more and more, right? So this Ozempic face is everywhere and that impacts our dentures. So we might need to see more and more patients for reline. And then rebasing. What about if the denture comes back and it's the wrong color, if the denture is really underextended or it gets over trimmed? And even in our partial frameworks, I rebase sometimes if the framework fits well, but the base is underextended because of weight loss in the patient. So regardless of whether it's an immediate, a definitive, a partial, when can't you reline or rebase? And you can't do it if the denture doesn't look good. It's not going to make the denture look better. So the teeth aren't changing when you're doing a reline or rebase. The teeth aren't going to change color. A partial framework that doesn't fit isn't going to start fitting better. If the tissue underneath is not healthy, you don't want to do a reline or rebase. In those cases, you want to do a tissue conditioner to treat the tissue and let it heal before you do something more permanent. If the patient has speech issues, a reline or rebase isn't going to help you because that's more from the contour of the palatal surface and the teeth positions themselves. If they have vertical dimension issues, a reline or rebase is usually not going to be enough to help you here. And if they have uneven occlusal contacts, it's only going to complicate the reline and rebase procedure. So you want to correct some of that occlusal issues before so that you have stability when you're relining and rebasing. So when you're relining, you can do this chairside or you can do this in the lab. If you're going to do it chairside, you want to know the material that's going to work best with your particular type of denture. So CoSoft is something that I use all the time. It's one of my favorite denture smells, right up there with vanilla endo ice. But it works really nice. It's really easy to use, and that works great, especially on traditional dentures. But on printed dentures, a lot of people see more success with the soft reliner. So this is a material that expresses much like a PVS. You're going to use a gun and it has a base and catalyst. It's going to mix and it's going to stick to printed dentures a lot nicer. You can use CoSoft in a printed denture if your printed denture is completely bone dry, but the soft reliner is a lot more forgiving on a printed denture. If you're going to do lab process denture, this is going to give you a little bit more long-term stability, but it does require the patient to go without their denture. So what you're going to do is you're going to take an impression inside their denture using their denture just like a custom tray, and then you're going to send that out to the lab. So the patient's going to be without their denture while the lab is turning everything you impressed into acrylic. So you can either impress it in a static way or a functional way. So a static way, you're just going to border mold and impress just like normal. Or you can even do a functional impression where you have the patient wear a resilient liner and they walk around with that for a few days until it like really settles in and hardens up more. And then you send that out to the lab. So when you're figuring out your vertical dimension, you want to make sure with your relines and rebases, you want to make sure you're not changing your patient's vertical accidentally. So look at the picture on the lower right, and you can see if the denture fits in the mouth and then you only seat it in the front, not the back, or you only seat it in the back and not the front, now you're going to change the patient's vertical and their whole occlusal plane without intending to, and you're not going to be happy with how it looks at the end. So you really want to make sure you're focusing on this as you're doing these reline methods, whether you're doing chairside or a lab reline. And because of that, it's always better to start with the unstable denture first. So if one denture is like pretty good and the other one's wobbly, I like to reline the wobbly denture first because the stable denture will help to position it in a repeatable way, so I have more predictability. Now, once I've relined, say, the lower denture, then I can reline my more stable upper denture compared to that now newly stabilized lower denture. Now, when you're taking your impression, you can either do it with a closed mouth posture or an open mouth posture, and there's pros and cons for each of them. So if you're doing a closed mouth impression, it's going to enable you to really know that you're at the accurate vertical dimension. So if both of the dentures are in the mouth at the same time and the patient closes with the material in, know that they're not going to accidentally have the denture be way too tall. But if you're relining or rebasing, say, a partial and you don't and you have them closed, you can't see to be sure the partial framework is seated down all the way onto their teeth. So when they're open, that's a benefit if you're doing a partial, that you can actually make sure the teeth and the breasts are sitting all the way down exactly as you want them to be. So what are you going to do if you're going to do a lab reline? You need to make space for the material to send to the lab. So you're going to trim your borders down 2 millimeters, just like imagine you're making a custom tray, and you're going to trim your tissue down about 1.5 millimeters. But you want to either leave stops, so areas that you're not going to trim away so that it doesn't change the patient's vertical, or you can add little stops into the denture with compound or even with heavy body PVS. And then you're going to remove any undercuts so you're able to take the impression. Then you will border mold just like you're making a new denture. And then you will take an impression and then you will send it off to the lab to have it added, have the new acrylic added in. So in terms of troubleshooting, in the last few minutes, we'll just go over what are the common issues that we often see in our immediate dentures. So the first thing that is everyone's worst nightmare is that it doesn't fit. So it's just not going in. So you want to make sure that there's not any border over extensions that are holding you up. So if the immediate doesn't seat, it's usually because the lab has over trimmed the cast at the extraction sites. So say the patient had teeth 6 to 11 left and it's not going in. Usually it's because teeth 6 to 11 were over trimmed on the cast. There's too much acrylic in that area. So I will trim at the sites on the denture where the teeth came out until I see the other areas of the denture that weren't involved in the extractions seat down. So that means the palate. The palate was not involved in the extractions. The palate should seat all the way down. If the palate's not touching, it's getting held up on something that changed, the area that we were guesstimating where the teeth came out. So you can check this with pit paste, but pit paste is hard to read and there's a lot of blood in the mouth, like I said. So another thing you can use is Fit Checker, and you mix the base and catalyst. It comes in the tubes and it also comes in the squeeze gun. I like the squeeze gun for crowns, but I prefer the tubes for dentures. And you can mix this and put it in and do like a wash impression with that, and that'll show you really well where is it binding up, what is stopping you from having it seat. If it seats almost all the way and rocks, the point at which it rocks and it's seesawing is the area that's holding you up. So when you do all of these steps, then you're able to get the patient in really comfortably. And when you're doing this, remember, I know sometimes people shy away from immediates, but immediates really change people's lives and it really changes their opportunities. This patient worked in a job where he could only work in the back end of retail. And when he got his immediate, he was able to go and be customer facing, and it gave him a lot of opportunities for promotion. So I find that immediates are one of the most rewarding things, and I really look forward to immediates now. So I don't want you guys to be intimidated by it. And the one other thing I would say that tends to happen with immediate dentures is cheek biting. So again, we didn't get to do a whole try-in because their natural dentition, their teeth were still in the way. So the patient might bite their cheek on insertion, or they'll come back at the 24-hour or 1 week follow-up and tell you they're biting their cheek. So if they're biting their cheek, it's because the back teeth on the upper are not holding the cheek far enough away. And so you want to make sure you have 1 millimeter of space from the outside of the upper tooth to the outside of the lower tooth. And if you don't have it, you can just trim the lower cusps to be a little bit thinner in order to keep that from being an edge to edge arrangement. That should take care of it if they're biting their cheek just because how the teeth are. If that doesn't take care of it, it's probably they need a little bit more vertical dimension. But usually I would say most of the time, because you were so careful in your earlier steps, you should be just fine. So with that, I will take any questions. Thank you guys so much for having me. It's always such a pleasure to lecture on Gladwell's study seminars.